morning everyone. So today's topic is double aortic arch and the anesthetic implications. So coming to the introduction, vascular rings have an incidence of between 1 in 1000 births and 1 in 10,000 births. It develops from aberrations of resorption of sixth embryonic aortic arches that connect the primitive dorsal and ventral aorta. So this is the classification of vascular ring, which include double aortic arch, right arch and left ligamentum, innominate artery compression of trachea, and fourth is pulmonary artery sling. So what is double aortic arch? So vascular rings accounts for 1 to 2% of all cardiovascular malformations, and majority, almost 40%, are of double aortic arch type, which results from persistence of fourth aortic arch. In double aortic arch, right aortic arch passes to the right of esophagus to join the left-sided descending aorta to form a complete vascular ring that encircles both trachea and esophagus. So the usual symptoms in infants or in the first 3 months of life would be respiratory distress, stridor, swallowing difficulties which develop within first 6 months of life, and subcostal retraction in severe obstruction. So if the patient is having swallowing difficulty, there could be chances of regurgitation and aspiration, and the tachypnea can present. Subtle tachypnea can become severe in those cases. So they will also be prone to the recurrent respiratory infections. So congenital heart abnormalities may be present in up to 20% of children with symptomatic vascular rings. So what are the various diagnostic investigations in this case? Chest X-ray with barium swallow, which was done before. But nowadays the modalities of choice for diagnosis of double aortic arch or vascular ring are CT angiography and MR angiography. Bronchography and bronchoscopy may be required to define functional changes, like to define tracheobronchomalacia, and transthoracic echocardiography to diagnose associated cardiac abnormalities. So what are the surgical approaches used for the correction of double aortic arch? The most commonly used is left thoracotomy, midline sternotomy when there are associated cardiac abnormalities. If a vascular ring is divided, such as one side of double aortic arch, it is critical to ensure that flow to all the parts of body is maintained. Test clamping and assessment of perfusion to limbs and head may be required. So what are anesthetic concerns and management? So in preoperative period, severity of obstruction and lung damage owing to the recurrent lung infections is relevant to the risk of difficulty with oxygenation and ventilation during surgery and in the postoperative period. Chest X-ray findings suggesting chronic lung disease, tachypnea at rest, rapid desaturation with crying. These are the three things which are important indicators of associated lung disease. Review of barium swallow, 2D echo, CT scan and MRI should be done, and the whole team should discuss and decide the optimal timing of surgery. For example, if the patient had lung infections or the lung disease, so should we optimize the lung function prior to surgery versus the risk of delaying the definitive therapy? So the risk and benefit ratio should be evaluated, and the plan should be taken care of. So what are the intraoperative monitoring which is required? Anesthesiologist and surgeon must have a clear plan regarding the need of lung isolation and discuss hemodynamic monitoring if temporary or permanent occlusion of blood vessels are a part of surgical plan. So ECG, arterial blood pressure, CVP, temperature, EtCO2, they're all necessary monitoring techniques. So if there's a tracheal narrowing from the vascular ring, it will usually not prevent endotracheal tube from being passed through the narrowing. It's rare that positive pressure ventilation and continuous positive airway pressure or PEEP will not be sufficient to allow ventilation during induction of anesthesia. A single lumen endotracheal tube is usually adequate for open thoracotomy and often acceptable for thoracoscopic procedure where lung retraction provide good surgical access. However, if there is a significant tracheal stenosis, so we'll go ahead with inhalational induction. It can be done with spontaneous ventilation using sevoflurane. Once patient is calm and relaxed, airway can be secured with endotracheal tube. ET tube is advanced into right bronchus to achieve one lung ventilation, and it is slowly withdrawn until bilateral air entry is achieved. The aim of doing this is to pass the endotracheal tube beyond stenotic area so that its distal end sits just above carina, and muscle relaxant or any muscle relaxant, for example vecuronium, is given only after securing airway. So when there is a mild tracheal stenosis which will not hamper passing endotracheal tube beyond the compression, but if there is significant stenosis, we may have to proceed with inhalational induction, achieve one lung ventilation and slowly withdraw the tube to make sure that endotracheal tube sits beyond the region of stenosis. So sometimes the tracheal reconstruction would be required, and that would be done on cardiopulmonary bypass. During this period of reconstruction, ET tube can be withdrawn proximal to the stenotic area, and stenotic portion can be excised and anastomosis is done. After the reconstruction, absence of air leak can be confirmed by filling surgical field with normal saline and giving positive pressure ventilation. So post-operative management, usually early post-operative extubation is preferred. Good analgesia should be ensured. Provided tracheomalacia and stenosis are not a problem, post-operative complications would include associated tracheomalacia, thoracic duct injury, phrenic nerve injury, and recurrent laryngeal nerve injury. So this is a patient having double aortic arch. This is the chest X-ray, lateral view and the PA view with barium swallow. So we can see the region of narrowing in the esophagus caused by double aortic arch in both EP and lateral view. So this is a diagrammatic representation to manage the patient with double aortic arch with significant tracheal stenosis. So there is the narrowing portion which is around 6 mm, and proximal and distally the trachea is normal. So to pass the tracheal tube just below the stenosis to achieve one lung, and then slowly it is to be withdrawn just above carina so that equal air entry is achieved bilaterally. And if at all the patient would need the tracheal reconstruction, ET tube can be withdrawn just above the incision line during surgery. Thank you.